Welcome everyone to our webinar today, seeing folks coming in the room. Thanks for joining us. I hope that if the weather is pleasant where you are, that you get a chance to enjoy it today. And if the weather isn't pleasant, that you can spend your evening somewhere comfortable and cozy away from whatever weather might be interfering with a sunny day. And give it a couple more minutes for folks to come in the room. But if you've joined us for past webinars, you know that we always like to sort of pose a question to get us started here. Ooh, oh my goodness, Michael, 60s in Michigan. Yes, I mean, gosh, I'm trying to think. I feel like that usually waits until probably June. Okay, everybody, let's do this. What is the weather like where you are? Let us know what you're dealing with outside your window or your clinical office or your car. 64 in Greensboro. Okay, so Desiree and Michael, you're wearing similar thing. Okay, 82 in Arizona, sunny, windy. Okay, ooh, Western Maine, bringing it in colder. Okay, sunny in San Diego. Ooh, yeah, Boston, 59. Okay, great. Oh, sorry, Karen, gray and gloomy in Oregon. Ooh, Pittsburgh, that's a little chilly. Seeing a lot of 60s, sunny in New Hampshire. St. Patrick's, 79 in Florida. Connecticut at 58. Okay, seeing the Pacific Northwest is coming in sort of with a cloudy 50s, overcast and cool. Allison, Mobile, Alabama, Karen, 72. Oh, Rebecca, I'm sorry you don't have a window, but yes, chilly in Michigan. Well, Michael said it was 60s in Michigan. I wonder if you guys are at different parts of the, as my friends call it, the mitten. 55 in Boone, North Carolina. Okay, 80s, Tina, yes, 80s in Texas. Why am I not surprised? Ooh, 90s in Arizona today. Okay. 55s in the Bay Area, Kimberly. Okay, so we've got, it doesn't seem like there's too much snow going on. So I take back my sort of vague references to warm and cozy by the fire. I think some of you who have those 80s and 90s, you probably were laughing at me when I was referencing warm and cozy fires. And so I think folks are still joining, but maybe we'll go ahead and get started now. And I'm in DC, and it's sort of in the 60s, and it's like partly cloudy, little bit of sun. So welcome everyone to the third webinar in our series, Making Integration Possible, Proactive Practices for Successful Collaboration. Next slide. So I'm your moderator for today. I'm Kristen Potterbush. Next slide. Leah, thank you for calling in from Canada. Completely fair that you don't understand our temperatures, but unusually cold. And love that we have you representing the international contingent. So a little bit about our organization. We're Primary Care Development Corporation. We're a nonprofit. We are focused around advancing health equity through doing work in primary care. We do that through a couple different lenses. That would be community investments. We've actually invested over $1 billion. Low interest loans through a certification from the US Treasury. We also do a lot in the space of providing expertise around trainings, webinars, national dissemination, coaching, and other sort of national programs to advance health education and promote positive health outcomes. And then also we work to advance policy initiatives in the health equity space. Next slide. So our disclaimer, the views and opinions and content that we express today in the presentation do not necessarily reflect the views, opinions, or policies of CMHS, SAMHSA, or the Department of Health and Human Services as a whole. Next slide. So this is a little bit about our year. We're at our third webinar. We've got one more webinar to go. And really what we're focusing on is the nuts and bolts of what makes integration happy. at your organization. So what it takes to get the policies in place, what it takes to get those gears going, just what it takes to leverage success and make this a positive experience, hopefully, and a practical one as well. Next slide. And so before we launch into today's webinar, just want to get a sense of folks who are in the room. We've gotten a sense of where you're calling in from. We've gotten a sense of what your weather's like today, but would love to know what sort of setting you work in. Would love to know, what you're working primarily as, and also want to acknowledge that this is in no way expected to be representative of who you are. I know we have a lot of folks that join us who represent all the multifaceted areas of what makes integrated care successful. So if you don't see yourself reflected on this poll, reflect yourself in our chat. Tell us who you are. Tell us that, you're not a nurse practitioner. Tell us that you're a respiratory therapist. Tell us that you're a peer. Excellent. Sharon works in the health plans. Ooh, yes, an integrated health navigator. Thank you, Haley. Yeah, let us know who. Ooh, thank you, Maria, clinical health psychologist. Ella, ooh, wonderful. QA coordinator, primary care social worker. Yes. Clinic managers, Michael, welcome. Health Foundations, wonderful integrated care setting social worker. Love seeing the social worker contingent state health department. Thank you for taking time out to be here. Senior Director, Practice Transformation, ACOs, wonderful. Public Health Departments, CCBHCs, yes. Oh, Pediatric Healthcare Integration. Wow, thank you, Wendy, for joining. Government, Quality Assurance Specialists. Okay, keep them coming, folks. Grateful to see everyone, and I think we're good to go to close the poll. Keep letting us know who you are. We want to recognize you if you're not recognized on paper here. So seeing a wonderful, seeing that almost half of the folks who are with us today are not reflected in the poll. I'm not surprised. We all know that what makes integration work is all of us, all of you on the call. So thank you so much, and definitely seeing that a little over half of folks today are already functioning within an integrated care setting, which is fantastic. And seeing more on the behavioral health setting side today represented, which is a little bit how we're gearing today's presentation. We're still going to have information for folks who are in primary care settings as well, of course. Wonderful. Thank you so much, folks. Next slide. Ooh, adolescents' brain and cognitive development. Very cool. Okay, so if y'all joined us last webinar, you might remember some of the topics we went over. But if you haven't joined us or you're interested in reviewing some of what our experts shared, we have created a tip sheet for you that really has the high level information. So we're gonna put that link in the chat right about now so that you can open that in your browser and download it after the presentation. But we wanted to acknowledge that sometimes you don't have the chance to sit through an entire webinar, and having a handy short list of the key topic areas can be supportive. So that'll be put in the chat, and we hope that folks find it beneficial. Next slide. So today we are graced with three of the experts who work here at PCDC. So I'm going to start with Dr. Ilse Bell. She is an expert in fostering practice transformation to ensure organizations can reach their medical home standards and align with the very best of practices. She leads work ranging from guiding organization requirements for value-based payments to supporting full stop accreditation processes. And then we have Deb, who will go after Dr. Ilse Bell. And she is our senior director here at PCDC. She leads the division where compliance frequently lives, which includes overseeing the patient-centered medical home, recognition work, among a whole host of other initiatives that really center around quality improvement work. And then Maia will wrap up our presentation today, and she is an expert at the intersection of compliance and community health. And she leads work with a variety of health organizations to ensure that, among other items, that their clinical and operational pathway developments are fully on track for success. And colleagues, if I left anything out about you that you want to make sure that folks on today's webinar know, please feel free. Next slide, please. So before I pass it off to Dr. Isabel, I want to remind folks that the slides and the recording will be available next week. A link will be sent out to all attendees. Maia especially is going to be going over some example slides. We're going to have some sort of sample documents in here. You might really want to download them. You can, of course, always take pictures with your phone, but we will be sending those out. You can absolutely get a copy of the slides. So want to make sure that folks are aware of that going in. And now I will pass the talking baton to my colleague, Dr. Bell. Oh, right, I forgot to go over the key objectives. My apologies, folks. So today, our key objectives are to identify the real-world mechanisms that support cross-team collaboration between providers within integrated care settings, to help you understand the aspects of the procedures and policies that facilitate all of the successful operation needed for supporting collaboration, and to review, as I was saying a little bit earlier, the concrete examples that can help inform how your organization can lay the foundations for effective integrated care planning. Next slide. Now I will pass the talking baton to my colleague, Dr. Bell.
Thank you. Thank you, Kristen. So thank you. I'm going to take the baton and introduce you to Alan. As you can see, Alan is going to be our case study for today, and he has quite a bit going on. From what you see listed here on the slide, he has a history of 2 chronic conditions, diabetes and hypertension. He has a 15-pack year history, as well as an elevated BMI. So when he presents to his doctor, Dr. Caring, he presents with a new complaint, which is fatigue, restlessness, and insomnia for the past 6 months. But there are 2 things that I want to draw your attention to. First is that he has not seen his primary care doctor in 6 months. So that's the first alarm. That's the first alarm bell that should be going off in everybody's brain. He's not been back to the doctor in 6 months. And what brought him into the doctor are completely new symptoms, which are the fatigue, restlessness, and the insomnia. Dr. Caring goes ahead and examines Alan and runs some initial tests, and then schedules him to come back to review those tests and go over everything that he thinks needs to be done as far as his treatment plan. Next slide, please. So this is what he reviews with him in the next 2 weeks. His labs, his previous medications, as well as the changes that he sees on medical exam. So everything that you see here in bold are changes from his previous condition and things that are not good. As Dr. Caring is going over all of these labs and these changes and explaining all of the things that have changed since his last visit, Alan listens very intently and then continues to share with Dr. Caring that he has been really struggling with his current diabetes regimen. And he doesn't quite understand why he's struggling. He's been taking the same oral medications, he's been using the same diet and exercise, but it just does not seem to be working for him. And along with these other symptoms, he just can't really, he's not really feeling quite like himself. All of this is really quite evident to Dr. Caring because he can tell from these labs that Alan has not been doing as well as he could and should be. Alan's hemoglobin A1C has increased from 8% to 9.2%. His cholesterol and LDL are now above normal when that was not an issue before. As I mentioned before, he only had 2 chronic conditions, which were diabetes and hypertension. There was no issue related to his cholesterol and LDL. But he believes that these changes in cholesterol and LDL may be a result of the increase in his BMI, which has gone up from 32 to 34. Additionally, his blood pressure, even though he's on an antihypertensive, is not as well controlled as it should be. His blood pressure is 145/85. Dr. Caring also reviews the PHQ-9 results and suggests that perhaps treatment for his depression, which at 20 is scored as severe, may also help him better control his diabetes. Next slide, please. So after a review of all these labs and the pertinent changes on physical exam with Alan, Dr. Caring has advised him that he's not going to change his medication regimen at this time. What he would like for him to do is to resume his previous medication and diet regimen. But in addition, he's going to add a nutrition referral, which he hopes will help him with that cholesterol and LDL issue that seems to have arisen, and that BMI issue. And he's also going to provide him with a referral for therapy for his depression. And he'd like to see him back in 3 months to see how he's doing. So although there have been some changes from his previous condition 6 months before, Dr. Caring decides that any significant changes in his medication regimen at this time would not be warranted, that there's something else going on that could be impacting not only how he's feeling, but his physical well-being. So he decides not to change that medication regimen at this time. Dr. Caring explains to Alan that he will work very closely with the therapist, Janice Soothing, to get him feeling healthy and back to feeling more like himself. Next slide, please. So let's just talk a little bit about this behavioral health referral. Is Dr. Caring referring him simply because Alan has a positive screen? Yes. Alan not only has a positive screen, Alan has a screen that is positive for severe depression. Surely he'll start to feel better once he starts to feel better, correct? So you may think, or some may think, that once he begins to eat better, perhaps exercise more, that he'll feel better physically. So then that fatigue and that insomnia and that restlessness will start to resolve, but not necessarily. So let's talk about that BH referral. Does Janice actually have a role in Alan's management plan? What you see here are a few thoughts and comments that we as a group at PCDC have jotted down to kind of get this conversation started. This is what we came up with in terms of what we think the role of behavioral health or a therapist could play in Alan's treatment or management. So I'd like for you to put in the chat if you agree or disagree, if you have any additional comments as to what the role Janice Soothing as a therapist could play in Alan's treatment plan. So what we've jotted down is that she, one, has no role, and that this can be managed completely by his PCP, that Janice can provide him simply with support in terms of maintaining his treatment regimen. She can work on behalf of Alan to speak with Dr. Caring about how depression and his care plan can intersect, and perhaps they can collaborate. Or she can also explain on behalf of Alan to Dr. Caring that, or how Alan's labs are impacting not only how he feels physically, but how he feels emotionally, and also provide Dr. Caring with some upskilling on his needs related to how to message to him more effectively. So there is definitely a role for Janice here, and it can play various roles. But so Leah says that the therapist has an important role in treatment. Agreed. Of course, the therapist should have a role. Therapeutic interventions in collaboration with PCP, exactly. Therapists can help with coping, behavioral changes needed, support for chronic conditions, etc. Yes, I think we're all on the same page. Exactly. Alan endorsed the idea that he's almost constantly thinking about, exactly. So clearly something is going on with Alan. He was maintaining a regimen before, and now something has happened that has resulted in him not being able to maintain that regimen. So there definitely is a need for behavioral health. And the intersection of primary care and behavioral health is very important now for Alan, because we want to make sure that both are going to be addressed such that neither one are going to be the ones to push him or move over the edge. Shouldn't the therapist be part of the treatment plan to begin with? That is a very good question. Now, what I didn't say in the beginning was that whether or not he had any behavioral health issues. Now, since I created Alan, we can say that perhaps he did or he didn't. But often what happens in primary care is the question goes unasked, so you don't know, which is why screening in primary care has become very important, because without that screening, patients don't very often volunteer their emotional state. They don't often come in saying, I feel this way, I feel bad, I feel, etc. So what Alan came in saying, I feel restless, I feel fatigued, I'm having insomnia, that's an improvement. Patients don't often do that. And so that's what prompted Dr. Caring to do the PHQ-9 screening. But irrespective of that, he should have been doing the screening anyway, to be able to level set, to figure out what was it that could potentially be causing Alan to no longer be able to maintain his current care. So referrals are problematic, and Alan will unlikely follow through. These chats are coming in too quickly for me. There should be a warm handoff. So that is actually a very, very, very good comment from Trusa. And again, because this is my case study and I get to kind of create this as we go along, what I have left unsaid is that Janice and Dr. Caring actually do have a collaborative relationship. So there is an element of warm handoff here that I have not described. So, but I see your point, and that is a valid point, that they're really the value of having integration in behavioral health, especially a physical warm handoff, is the best way to ensure that patients are actually going to follow through on that behavioral health referral. Absolutely. Next slide, please. But this slide, I think, says everything in 3 words. Communication is key. Whether you have the provider stepping out of the room and bringing the behavioral health provider into the room, whether you have the behavioral health provider on the phone with the patient in the room with the primary care provider, communication is key. And letting the patient know that the primary care provider is endorsing the involvement of behavioral health in their care is also very important. That lets the patient know that the referral or this warm handoff is part of their overall treatment plan. So the communication piece between both of the providers, between them and the patient, is very important. So boiling everything that we've said, everything we said in the chat, down to one central theme is communication is is key. Next slide, please. So it bears repeating again, behavioral health integration is a value add, full stop. Listed here are just a few reasons that have been validated by research that that statement is true, that behavioral health integration is a value add. All of the things that you've said in the chat absolutely support all of the things that you see here on the slide. Everything that behavioral health can provide to patients is supported by research in terms of them being able to help providers as well as help patients link the emotional and the physical, whether that be symptoms, whether that be treatments, everything. So for Alan in particular, he may not be able to express to Dr. Caring what it was or whatever the inciting event may have been that caused him to no longer be able to care for himself, to put himself first. But Janice can help him get to the bottom of that and help him reprioritize. And in conjunction with Dr. Caring, help bring all of those things back into management, bring all of those things back into his priorities so that he now understands, I've got to put myself first. I've got to make sure that I'm well enough to be able to take care of my family and all of my responsibilities for my family. So again, if you can share in the chat any more ways that you believe that or you feel that behavioral health providers can be critical partners. Language is key. Therapists can explore other issues, concerns shared by patients at PCPs. Let's see. Oh, Kristen, I'm not as good at the chat as you are. No, not only can behavioral health help in the moment, mental health can also build preventative measures for relapse and mental health. Absolutely. I agree with that 100%. Let's see. Anything else? Okay. You're coming in too fast for me. So if I missed your point, I apologize. But I think we're giving the medical folks education around, I'm missing them again, giving the medical folks education around how best to approach patients, et cetera. The one thing here that I really liked was the focusing on the person-centered goals. You know, clinicians for a very long time have used, the A1Cs and all of the clinical levels as the goals for patients, but that doesn't always translate for patients. And so if you focus them on the things that matter to them, and I think behavioral health has done this for eons. And so that's someplace I think, actually, that's something that I think behavioral health providers actually do much better than primary care providers do. They help patients figure out, well, what is your motivation? The CDC back in 2019 had this campaign called What is Your Why? And the whole focus of that campaign was getting people to understand what their motivation is. So what is your why for doing or not doing X? And so behavioral health, I think, understands that motivation, getting people to kind of center themselves and figure out what their why is and putting that why to paper. And then for the behavioral health provider to then be able to speak that language to the primary care provider to translate for them. This is what the patient said. Can we translate that into something that for you clinically makes sense, but makes sense for emotionally or personally for the patient? So that third bullet was kind of like the sine qua non for me. But we can move on to the next slide. Yeah, Kristen, you're managing the chat much better than I am. So, okay, so navigating each other's words. So this goes back to the comment that someone made about the language and using the right language. So we should always be mindful as we collaborate to speak plainly and simply. So I just threw out A1C. That's something that's kind of like in my lexicon, that's in my swim lane. And that's kind of what we tend to do. We tend to speak in acronyms and, the shorthand of our world. I heard a reporter saying one time that that words are the coin of their realm. That's what journalists and reporters do. And so acronyms and shorthand can be thought of the same. That's the coin of your realm. And so when you speak and you trade in that coin, you forget sometimes that other colleagues have their own shorthand and they have their own acronyms. And so you end up kind of talking at each other and not really talking to each other. So just be mindful as you collaborate to speak plainly and speak simply, so that we're speaking to each other with the intent of what's best for the patient and getting down to the simplest common denominator. Next slide, please. This is, we're just providing, we're big on cheat sheets. So we're providing this as a cheat sheet just for some of our behavioral health colleagues. So when you see some of these letters and descriptions in a chart, you'll kind of know what they stand for. This is by no means an exhaustive list. And I kind of thought when I was originally going to put this together to also include some ranges for labs, but each lab has their own range. So it wouldn't really be that helpful. So we thought that perhaps if we at least give you some abbreviations to kind of get you started, but this again is just the starter. So really what this is intended to do is just help open the door for that communication that you're going to have with your primary care colleagues. Next slide, please. So last but not least, let's go back to some of that lingo, some of the coin that I kind of dropped earlier. So I said that this patient that Alan had type 2 diabetes. So, diabetes, as we all know, is the inability of the body to handle sugar. But what makes this particularly destructive is that if it's left untreated, it can result in all types of complications. So for Alan, his inability to control his blood sugar, which is indicated by that A1C level, is concerning to Dr. Caring. Hypertension is a rise in your blood pressure. The rate for blood pressure now has gone down. So a normal blood pressure should be less than 120/80. Systolic is the number on top. Diastolic is the number on the bottom. The BMI, as we all know, is the body mass index, which is different based on your gender and based on your race. And unfortunately, really should be adjusted for your body type as well, but is not. So, his being a 34, we don't know if that means that he's very muscular. We're going to assume that he's not, because in 6 months he went up by, it went up from 32 to 34, which usually is not muscle mass, but A1C, this is again a measure of the level of the blood circulating in your body over a period of months, which is one of the many tests that can be used to screen for diabetes. So what this tells Dr. Caring is that Alan has not been managing his diabetes for several months. And that's, again, concerning. And then again, the cholesterol and LDL are just a measure of cardiac health. So he was doing pretty well, and 8% for diabetic is not bad. It's high, but it's not bad. And then it going higher, and now you're adding some issues that may say that he's going to have some issues with his heart is concerning. So adding on a behavioral health provider definitely, I think, was the right thing to do at this point. I agree, probably should have been done before, but Dr. Caring he's new to the behavioral health integration part of this primary care trajectory. So we have to meet him where he is. I am at the end of my slides. So I'm going to now hand it off to, I believe it's Deb. Is Deb next up?
I think I am.
Yes.
Oh, no, that's not me.
Is this Kristen?
No, I'm just the friendly moderator today. Go one more slide. Let's figure it out. Maia, Deb, are either of these slides yours? Let's just advance through. Welcome.
I was about to say, well, let's just go anyway.
Let's just go through until we find some slides.
I see the word EHR and I feel like a Pavlov's dog. I automatically respond to that.
Okay. Is this, welcome folks to what occasionally happens in the integrated care environment, which is we have to collaborate on the fly live in front of people to sort out what to do next. Okay, these are your slides now, Deb?
Yes, yes.
Perfect.
So everything that Ilse mentioned is amazing, right? You have this example of this patient presenting to the primary care provider. You have this opportunity with support, a behavioral health support. I've been reading the chat. I know Ilse, you didn't get a chance to reach. I've been reading the chat, and the chat is even responding to the fact that what word we use for that individual that we hand off to, from the primary care to the behavioral health, even we have to be careful with that, and that sometimes patients are taken aback with this term therapist. So considering even that, all these things that we consider in this integrated model, we have to do by publishing sort of like a mechanism on how we're going to do it. Each organization, as they decide to go to the journey, go through the journey of behavioral health integration and then making it work, right? Where both parties, both the behavioral health clinicians and the primary care clinicians, see that there's parity in their work and respect within their work, but also how combined together that they would be thinking about the patient and their needs at the end of the day. So I say all to say that you need a policy to do behavioral health integration. And a policy, unlike a procedure, is just saying, this is what our intent is. Our intent is to have behavioral health integration. The procedure is where you sort of pull up your sleeves and dig into it, because now the procedure is the actionable component. The actionable component of a policy is the procedure, and therefore the procedure now reduces any variability, typically, on how you roll out the intent of the policy. And hopefully me using these policy and procedure words are not sort of confusing, but I'm trying to make sure we're all very clear, because everyone hears this term policy and procedure. And as we do a lot of the work in transformation and compliance, the compliance work that we see is the lack of respect from a policy statement and a procedure and how it's delivered, and who actually gets to now chime in on procedurally how you use the staff to sort of carry out some of this work. The procedure details the process that supports the policy statement in most respect, but more importantly, it's a list of instructions for the people who need to do the work. So if you onboard someone in an organization and you say you have a behavioral health integrated model, we have these 4 or 5 care team members. Each member should know exactly what their scope is, and more importantly, where they start and then where someone else may pick up for the literally the impact of making sure that the patient's care is continuous and seamless throughout the encounter. And that means even if they had to have this warm handoff to behavioral health, started in the primary care, or they started with physical health and had to warm off, it shouldn't seem disjointed in that process. So like I put here on my slide, the devil's in the details. A policy statement sounds really nice. The procedure makes it real. And if you don't say it the right way, then anyone reading the procedure will be like, I have no idea what you're talking about, because you made it so complex that I need a PhD just to figure out what I'm supposed to do. Well, most of the people do have PhDs doing the work, but the problem is it should be clear, simple, plain language to give instructions to team members so they know clearly what they need to do. Stakeholders should be involved in this process. So if you are an organization that has this behavioral health integrated model and you've decided to sort of make it factual by deploying a behavioral health integrated policy and procedure, a workflow, if you don't want to use the term policy procedure, a workflow, a memo that was distributed to the team members that are going to carry out the work, The stakeholders should have had some say in how you do that work. And when I say stakeholders, I mean, who are the people who are going to be instructed to carry out these activities? That's the staff, right? So I have a question for you all. Next slide. Question for you all. Have you reviewed your organization's policy and procedure related to behavioral health integration? And I guess for those of you who don't have an integrated model yet, but certainly are thinking about it, I want you to really think about this in terms of how you plan to deploy this. But for those of you who do have it, let me know. Have you read them? Have you not read them? But you know they exist. And then no, you haven't read them and you're not even sure they exist. Oh, no, you answer the poll. You don't write the answer down. I don't mind you chatting it, but answer the poll in response to this. Wow, so Mallory is saying she's, oh, you got to write them, but you're, okay, that's a tough one. So Haim, let me know. How do we fare in this response? Okay, so we have 45% of you have read them. Congratulations, but we do have some that said, no, I haven't read them. And some have even said, I haven't read them. I don't even know if they exist. And this, the reason why we pose the question is obviously it's a problem, right? And we go do work that we do on a daily basis. And unfortunately, rules and regs are now created, distributed, and pushed down. And, you know, it's just no time to digest it all. It's really difficult out there. So I encourage you all, if you are in an integrated behavioral health model, if you do not have a policy and procedure, start with developing some sort of written out workflow. And this will help benefit any new person coming on board to your organization. Just the workflow gives some credence to, this is what I do, and this is how I hand off. And typically this is what I look for before I hand off. And then this is what our support then does thereafter. So I encourage you to do that. Next slide. So we're going to talk a little bit about procedures, because I think everyone sort of says, oh yes, we do behavioral health integration by some aspect, but sort of don't dig into like who does what and then when, which is most important. So as I mentioned, procedures detail activities, be specific to the staff tasked to conduct the activities. We work with an organization that was so specific to the staff that they drew together a diagram that had an x-axis and a y-axis, and literally for every task, let's just say for depression screening, from the time that patient walked in the door to the time that patient exited the building, the process of who conducts the depression screening, if the result is then X and not Y, then who does what, like all those details were incorporated in that. And why did they do that? They did that because one, they wanted to reduce the variability, but two, they were offering yet a new service to their physical health practices, and patients weren't used to that. So they had to be an opportunity to make sure that the staff were sort of geared up and ready to respond to patients and be like, why are you asking me if I'm depressed, right? They needed to inform and engage their staff to be able to be responsive to the work. So I encourage you to think about when you are doing your policies, writing them out, and then thinking about the underpinnings of it, which is the procedure, that you consider some things in that document. So as I mentioned, you convene your stakeholders to develop this sort of integrated care model. Why? Because although you might be a primary care setting and bringing on physical health, you need both of those parties and the scope of service that they render to have an equal complemented stake in what you now put together as a recommended way to communicate and support the patients at the end of the day. You allow for the doers to walk through the process. So don't write the policy and, you know, think it's good and roll it out. And somebody comes back to you and says, well, what made you think we even had that in place to do X, Y, and Z? So don't make it a thing until you PDSA the procedure to ensure that you sort of address all the possible kinks. So allowing the doers to say, okay, theoretically, if I did what you suggested I do here, this is how the visit would be, this is how long the visit would take. So if you're putting something together and you're not considering the time, the in-kind time, the prep time, the pre-visit time, the after-visit time, coordinating the patient to get to another sort of higher level support or behavioral health support, all of that should be considered and thought about when putting together your procedure, right? You should also include communication among staff on when and how to enter stuff in an EHR. We all have EHRs. And the number one thing that sort of falters, unfortunately, is you start a new process and then it comes time to put it into this devilish thing called technology, right? And everyone's assuming somebody else got it in there and no one's got it in there. And at the end of the day, you look at your, well, how much depression screening have we done? And it comes up with a number much lower than you all expect. And you're wondering, how did that happen? And that's because, oh, you were supposed to put it here in the EHR, then click this button and open up this panel, and then you click this button, and then the EMR screen explodes, and you click this button that stops the explosion. Like all this stuff has to happen, but no one sort of walked through the process of making it be able to be adjudicated within the EHR system. So you want to consider that. That all should be in your procedure when you create your policy and procedure, because if you don't, you're leaving that up to lots of variability. Lots of variability for some means, well, at the end of the day, it wasn't in the policy, so I don't necessarily have to do it that way. At the end, you want to state a method of monitoring and measurement. Again, if you're going to have an integrated care model, there might be some, I'm not always, but there might be some mechanism for you to determine, is the model that you adopted successful? What constitute for success, right? Is it how many handoffs ended up being that treatment was followed, and how long was treatment followed? You're going to measure 3 months, 6 months, 9 months as treatment follow-up. Are you going to measure how many times that you've done sort of regression screenings once a patient has been identified as depressed? It doesn't matter, but so long as it makes sense, whatever that mechanism of measurement is, it makes sense to those in the organization who are doing the work. So again, their input is critical from the beginning, because at the end of the day, what makes for successful behavioral health integration? Primary care doctor, let us know what makes for successful behavioral integration. Behavioral health provider, let us know. How do you define success? Because if you're looking at these two groups to come together and it have a unified model on onset, it's not going to work that way. Their training wasn't sort of done in that way for it to sort of automatically fit together nicely of a puzzle. It doesn't work that way. You have to work at it. And let me repeat that. You have to work at it. And for those of you who are behavioral health integrated models, I can guarantee every time you get a new team member that joins the organization, that personality type, you need to work on it to bring everybody under the same accord and same fold. Next slide. So as Ilse had mentioned, the communication piece is so critical. It is just like literally the beginning and the end of how all this stuff sort of works. Communication. And again, it takes time to communicate, which is typically the issue that we see often. So in this example, the PCP is looking for a specific clinical marker during the encounter. And we see that oftentimes, as Ilse demonstrated in her slide showing the labs, the clinical markers is how the providers decide and gauge what the course of treatment would be. Behavioral health providers look for social emotional markers with other things as well, right? But when they have this value add of having the physician give them some, well, let me tell you a little bit about this patient clinically, and then the behavioral health provider has a wealth of information understanding from a social and emotional perspective, you can make for a really great combined care plan for an individual patient. So both of these professionals have screening tools, yet patients fall through the cracks. And they fall through the cracks due to sometimes a lack of communication. And someone had chatted that oftentimes physicians may not be as tickled enough to want to hand off their patient, right? Because they think clinically, thinking about the clinical markers, that there are certain things that they can address, because that needs to be addressed before any sort of social emotional component is now supported. So in this example, I'm asking the question, the PCP warm handoff to behavioral health, yes or no? I'm asking the question. The patient presents diabetic, patient post-hospitalization encounter diagnosis the diagnosis was they were not taking their medications, and they CHF. They have a history of not taking their meds. They screened positive for mild depression today, but severe depression over the past 2 years. Provider encourages to change diet, take meds, check blood sugar regularly. 4 months later, the patient arrives to the ED with a blood pressure level of 240. With a blood sugar level of 240. So I'm asking you in the chat, would this patient have benefited from that visit post-ED discharge? Would they have benefited having that depression screening done with mild depression? Would they have benefited having a behavioral health provider intervene? And you can put that in the chat. Yes, yes, Mallory, yes. Especially with the history of severe depression. Sounds to me, or looks to me, that a patient with these diagnoses, these levels of comorbidity, that certainly there is some unawareness of that, them trying to perhaps harm themselves, using medicine almost to harm themselves, or lack of caring for themselves, or doing what they need to do to result in the fact that they're yet back in the hospital again. Yes. Yes, Anna, to address the barriers of medication. The barriers, it's like, what's happening? Why are you not taking your meds? And let's not forget, providers do this, right? Physicians do this all the time. You need to take your meds. You need to take your meds. You need to take your meds. I'm getting a pharmacy alert that says you haven't picked up your scripts. You need to take your meds. But that behavioral health piece would dig in and say, well, let's take a minute and figure out why do you refuse, or why do you insist on not taking your meds? And it could be a real reason on why that's not happening. Next slide. So I'm going to close with, these are some things that we consider to be behavioral health integration procedural considerations. Make your policy statement what it is, but consider these components when you're putting together your procedures. Again, primary care providers are the central point of medical access for many patients. You cannot put together a procedure without including the primary care provider, period. As Ilse said, they bless sometimes this handoff. They bless the referral to behavioral health, and patients really rely on them as a gauge. They don't always listen to them, fortunately, but they do rely on them, and they do value their input and feedback in many respects. Allow for stakeholder input to develop a sustainable process. Again, if I had a part in putting together the policy and procedure for my organization, I'd be way more engaging when I realized, the suggestion I made ain't working out so well. Let me now bring that back up to the leadership, right? I'm a worker bee, but I want to now let them know something is awry. Spread tasks to care team members. Your policy and procedure should not be a one and done. All these things need to happen, and you guys pick whoever gets to do it. You need to enumerate or annotate who does what in your procedure, and you got to spread that love in the who does what in the procedure. If you give it back to all the clinicians and the therapists, guess what? It ain't going to happen. It's not going to all get done. You need to include the care team. Inform and engage staff, support, inform and engage patients. If you don't educate and inform your staff, they are less likely to be able to support what you're trying to get accomplished in terms of goals, functional lifestyle goals for your patients. They reiterate, they reinforce it when they talk to the patients, right? Behavioral providers are trained to elicit patient treatment goals that intersect with the patient's lifestyle goals. They understand what's going on at home. They communicate and want to understand what's what's making you do this, Deborah, as an example? And what's going on at home, Deborah? Are you feeling any stressors at home, Deborah? That they can go in on that and feel very comfortable going in on that because that is their scope. And then finally, but not less important, but certainly in the theme in which we've been talking about, ask patients permission to conduct a handoff. They may say no the first time, but when you ask them that, you are now automatically including them in that decision-making tree. And Ilse had already mentioned it. I think it was in the chat quite a bit. They have the ultimate say on their care plan. They have the ultimate say on their treatment. Why? Because they do it at home, right? They don't do it in the auspices of your medical practices and they do it at home. In your clinics, they don't treat themselves in your clinics. They do all that work at home. So if they have not engaged, they have not agreed to it, if they're not on board, it ain't gonna happen. I think I'm going to turn over to my colleague, Maia, and she's going to show you how this may look.
Hi, everyone. I'm Maia Morse, and I'm going to bring it home today with a little discussion about integrated care planning, which I really feel like is the pinnacle of integration when we actually have a shared care plan. And it's also a fantastic means of communication. I feel like communication has sort of been the theme of today's presentation. And this is just one type of communication, but can be extremely effective. Next slide. So what do we really need to think about when we are developing an integrated care plan? What are the fundamental components? And what are also some possible limitations? And I'm thinking here in terms of the handoff of the care plan, how often it's being touched. All these items really bring us back to what Deborah was talking about related to having a policy, having a clear procedure that outlines who is doing what at what point during the visit. So let's take a look at a few examples. Okay, so this first screenshot is really showing us that the integrated care team is very clearly laid out in the care plan itself. I really love this. And in this particular circumstance, there was a PCP and there was also a social work listed. But there could be other members contributing to this care plan. This just happened to be the example here. You can also see that there's very clear sign off by the various provider who is making the updates at any given time. And so I think that that's really important because we want to make sure that different parts of the care plan, you know, it's clear who mentioned it and who wrote it so that another care provider can go back and ask them any questions about it and follow up, send direct messages as needed. Next slide. Now, when we really get into the heart of the care plan, the piece that really stuck out to me here was around patient-stated goals. So that's really the first part. And we do actually a lot of work around patient-centered medical home. Care planning is a critical piece, and it's actually one of the most challenging pieces for organizations to maintain sort of in between recognition periods, because it is very robust. It does rely on a lot of different folks. But one of the core elements of care planning for sort of governing bodies that are looking at this is that the patient is stating the goal, that it isn't all goals that are assigned by the provider. And so what I thought was really cool about this template is that it actually allows for that. It clearly designates a spot where we can have the patient stated goal and then all the other goals that may be related to that underneath. It also points out how we are tracking and addressing goals. Of course, you know, that's very important. And if you look through the goals for this particular patient, it's very clear that the majority of these goals are related to behavioral health, but it's also possible that, you know, there are other more medical related goals. I don't think this particular patient has diabetes, but certainly if they did, then it would all land on this care plan. Next slide. So there is also a shared medication list, and you're probably noticing a little bit of a theme. We have a shared single care team, we have a single list of goals, and we have a single medication list that's shared among providers. So if a provider of one type adds a medication, it's extremely visible to the entire care team. I think this is really important. It allows for less duplication of work. And, you know, even without actually meeting and having a case conference about this patient, it allows for everybody to be on the same page about who's describing what at what time. Next slide. And the last piece on this particular care plan was the identification of goals and the corresponding provider. So again, we saw this a little bit prior, but this is extra emphasis on it throughout this care plan. And we actually, I got to see, you know, several different pieces of the care plan. The protocol, and I do say protocol because it was laid out in a policy, is that it's updated at least every 6 months, if not much sooner than that. And it was very clear which provider was updating it at any given time and at regular intervals. Okay, so next slide. I know we are running out of time, or we've already run out of time perhaps, but for those of you that can stay, I did want to ask, you know, what do you think of this integrated care plan? And do you have an integrated care plan? And then what's missing? What might be better about this care plan? So feel free to chat it in.
Maya, we're just gonna transition into
Sure,
the
okay.
Q&A office hours whenever you're done reviewing these policies. So folks, if you were here for the open office half hour, we're just gonna start that when Maya's done with her fantastic example policies here.
So just looking at the chat, there's actually a great resource that Alexander provided, thank you, around patient-centered integrated care plans. I look forward to viewing the video. Thank you for sharing the link. Additional comments, feedback, anything missing, anything better? Okay, then we might as well go to the next slide. And I believe that is really our wrap-up slide. Ilse, do you want to sort of wrap us up and close us out?
Sure. So very quickly, the good news is that the future is bright in that as it relates to graduate medical education, it's changing finally, ... The industry, I start laughing because I say industry, and then my friends are like, industry, why do you call it industry? Because that's the way I consider it. But there has been a shift in thinking, and that shift has now included turning towards all of the things that we've talked about today, namely using the tools like motivational interviewing and patient-centeredness and focusing really on culturally relevant care. All of those pieces are now being taught in medical school, and they were not when I was in school. So I think that just shows you how important all of these things are for the future of medical care. And again, just to reiterate and emphasize that the research has really demonstrated that there is some value here, and we need to keep pushing that forward. There is value here. There is value here. There is value here. We can't say that more than enough. And that the primary care support of behavioral health is very important. And that sign off is just saying to a patient that I think that this is what you need, and that this person is going to help us get you better, is usually and can sometimes be the one thing that will get that patient to at least consider that they may have or be in need of emotional support. And again, that emphasis on functional goals, making that patient-centered goal the crux to that aha moment for them, and making them a priority again. So essentially, I just wanted to wrap up there, but thank all of you for, on behalf of myself and my other colleague speakers this morning, thank you this afternoon. Thank you for all of your time this afternoon. We appreciate you being here and staying on for us. And we can now move into the Q&A session. Thank you, Kristen. I'll hand it back to you.
Perfect. Thank you so much. And thank you everyone who's hanging on for our Q&A. So we're going to put up a little poll here just to get a sense here of where folks feel that they're at. And then if you have questions or ideas, or we've gotten some resources shared today, go ahead and put those in the chat. This is the time where you can ask our wonderful experts on the call, if I do say so myself, questions that you might have. So I know folks were sharing earlier, you might be tasked with writing some of the policies around this at your organization. Or maybe you're struggling with collaborating with primary care, or maybe you're a primary care provider looking to collaborate in a new or different way with your behavioral health colleagues. This is the time to share what you're struggling with, to share what you'd like to learn, and to ask any sort of in the weeds or detailed questions. So go ahead and go to the next slide. This is our office hours. So yeah, if folks have questions, we'll just be hanging out here on the line. I guess, Chaim, if you want to go to the next one, I can do a wrap up if folks want to take a minute to start putting your questions in the chat. So this webinar series is funded through the SAMHSA Center of Excellence, which is housed at the National Council for Mental Wellbeing. And they have some upcoming office hours and webinars that folks are welcome to participate in as well. If you want to continue to upskill around these or any other topics, they also have a number of free resources as well. Next slide. So if you want to reach out to us, that's my email address. You're welcome to email me. I know some folks did last time, and that was lovely. If you want to check out some of our previous series from last year, the year before, you can do that at pcdc.org/sleep or pcdc.org/diabetes. Oh, Alicia, yes, absolutely. Chaim, can you go back to the next upcoming webinars? And again, these slides will be sent out. So if anyone wants to go over those policies and plans that Maia had with a fine-tooth comb, you'll be able to see it on there. And then of course you can look at these. Ta-da! I'm not seeing any questions come in specifically. Oh, thank you, Desiree. You too. Oh, here we go. Melissa. So it looks like Melissa oversees health homes. Thank you for doing that work on the health home program, Melissa. And you would love to find a way to get behavioral health providers and medical providers to coordinate with each other, and then additionally get the medical providers to communicate with us. So the coordinating care regarding mutual clients, requested records, etc. You find that there are a lot of providers who just don't respond, and it completely makes sense that you are frustrated. Which one of Maia, Deb, Dr. Bell, which one of you wants to address that question?
It's a lot of questions. It's a big old question. So maybe we could break it down in terms of getting the medical providers to coordinate better with the behavioral health providers. And I think that is a sort of like, you need to put them into a meeting, virtually, physically, and, have that conversation about what is your purpose and what is the goal and what's missing on each side, so that they can see that that deficit is now impacting how they deliver care, more importantly. So what do they both need from each other? And they draw together a compact. Like, you facilitate the conversation, but they have to take the ownership and decide, as professionals, this is how we decided that we're going to coordinate this effort.
And if I may, I am going to probably say you can take a different tactic as well, in that, not to speak for the providers, but sometimes what can happen is there's a feeling that this is just going to give me more work. And so not that it's the right thing to do to ignore it, because it's never appropriate to ignore a colleague. Certainly, I'm not saying that, but that may have something to do with why the requests are completely being ignored. The feeling is that there's going to be a lot of work. So I absolutely agree with pulling them to a meeting. But what I would suggest is that that meeting include management, and that everyone is clear that this collaboration is being blessed by management, and it is being expected of everyone that you work together as a team. One of the things when I'm working with practices, as I think all of us do this, when we're working with practices on any sort of transformation process, is when you are asking anyone to collaborate and do something or do something different, add it to their job responsibilities. And what that does is it puts them on the hook for it, and it brings it into a new level of importance for them. And so having the meeting is the first step, but you're going to have to take some other steps after it. And it may take, a few iterations of meetings to kind of get everybody on the same board and on the same plate, and I said board and plate, and I meant page, good grief. So on the same page. So, I think there are several ways that you can approach this, but I definitely think that, getting management to bless the collaboration and setting up some expectations around who's going to do what and what it's going to look like, so everybody understands their swim lane. So when we ask you to respond, we're asking you for this specifically. And if you give us this, we can do what we need to do. And then we'll come back if we need to ask for something more, so that, both sides understand we're going to each do what we need to do independently, but then this is where we're going to come together for the betterment of all of our patients. So hopefully that helps. But I certainly would love to see or hear from you again in any future webinars, if how you're going with that, because it's worked before.
Yeah. And I think I would also just add an additional perspective on this, Melissa. And I think that sometimes it can really help, at least with organizations I've worked with, to help set up something that folks feel like they're working towards together. And so that can be an opportunity for behavioral health providers, primary care providers, oral health, whomever else is part of your multifaceted or integration model, to agree that success looks like this. So success looks like us touching base X amount of time. Success looks like us communicating about these key areas and setting some sort of shared expectations. And I feel like that almost transitions us, and I'm not trying to skip your comment, Betsy, transitions us a little bit to Alicia's comment around providers potentially being resistant to have behavioral health come into an exam room. I've heard that on the flip side as well. I've heard, behavioral health being concerned that they're somehow potentially breaching trust. A client came to speak with them, and now they're saying, hey, you've got to go talk to a primary care provider. And I think that it comes a little bit again to expectations of, we are a practice that, as Deb and Dr. Bell were articulating, we are a practice that works together to ensure the best possible outcomes for our clients. And then talking to providers so that they're understanding that, and also kind of marketing it a little bit to clients and saying one of the unique things about coming here is that you have access to a variety of different services. And I think the point was made earlier, and I think a lot of us agree that not all clients who come into primary care are going to feel comfortable with being given a warm handoff to someone who is called a therapist. But there are ways to say, there might, maybe you could talk to somebody, or, we have some folks here that, you could join a group and have a conversation with. But it can be really helpful to, again, set a foundation of expectations about what success is going to look like with providers that are all collaborating together. And yes, that goes back to Melissa's comment. It also means there's an expectation of responsiveness around, this is what we do at our organization. This is how we provide care. And, I think it goes also, again, if you tell providers that clients are expecting potentially, that you're going to be able to provide care for all the components that make them healthy, to quote CFHA's definition of integrated care, that sometimes that can help providers feel a little bit more willing to bring folks into the room. And I'm not meaning to run through all of these questions. I'm going to pass it off for my colleagues who know so much more than me to pipe in and fill in any blanks. But I think that takes us a little bit to Betsy's around resources for when you have a new provider in the system. How do you prevent a situation like Alicia's detailing here, where providers might be resistant? How do you set the norm around folks communicating so you don't have a situation like the one that Melissa is talking about? And I don't think that there's necessarily a magic sauce. I think it goes to what Deb was saying earlier about, it takes a lot of work. We do some trainings at PCDC. I don't think we have any specific resources, unfortunately, that I could send you. But if folks are on the call and you have a best practice for onboarding new providers, send it in. There are some, though, around actually the hiring process to help folks become aware of what the expectations of them will be to function within an integrated care environment. And I think it's wonderful that your CMO is speaking about it, but I think, yes, it's something that folks have to get used to practicing, and it can be something folks have to adapt to. So I'm going to stop running through all these questions and, check Maia, if you want to chime in, or Deb or Ilse. I know we have some other questions coming in as well, but anything that I sort of missed in that blended Melissa, Betsy, Alicia answer?
No, I can't think of anything, but I did go back in and I see that Melissa added a little bit more context to her question, which is that she doesn't really have the authority to pull people into a meeting. So yeah, that does make it more difficult to get that problem resolved.
Can I respond to that? Because this happens constantly, and I think this is folks are set up for failure. Whole processes are set up for failure. Someone pushed down on you, and your leadership might be on the call, and I apologize in advance, but I'm just saying what is factual. Don't deploy a task to get done by an individual and give them zero authority, but all the accountability for when it doesn't work. And to be tasked to do something, and you cannot rally people to respond to an email or to say, show up to this meeting, but yet I'm no one's boss. You don't have to be the boss, but someone should have someone else hire that does have the authority to rally those groups, should have made that happen. And then the handoff to you would be seamless so that you can then now do the work with, pushing up the sleeves and doing the work. And when I say this is like an organizational fail that is constantly seen by us, because we're outsiders, we can diagnose what goes wrong in organizations. When everything's going well, it's great, right? But the number one thing that goes wrong is this. You decide you're going to do something, you create this whole like, oh, we're going to do it, yeah. And then you give no one the ability to make it happen realistically within the organization. And it's sad. You need the authority. I'm just going to say it. And I'm quite honestly, I've worked with physicians. I know when I have to grab another physician to basically get the blessing to work with a physician, because I'm not a physician, right? I work with physicians. I'm an operations person. There's this sort of this is hierarchy that exists in healthcare. We don't like to talk about it, but it exists in healthcare. And those of us who are operations folk, we can't rally those other people without having the hierarchy bless the work. So I feel for you as you're trying to get this done, but this is a problem that we see, especially with nonprofits, and it needs to be fixed.
Yeah. So it looks like Tina has asked a question. I'm just sort of going in order here. Is asking if there are examples of care pathways or procedures for different conditions, for instance, alcohol use, depression, diabetes, that you can use as a basis or template when developing your own. Maia?
I mean, it's a great question. I haven't seen any specifically, but certainly I could go back to the practice that I received the example from and see what they have. It would be nice. It would be very nice. Something we can consider producing for another round, right?
I have now, of course, now where to find them. I will dig in the archives and I will send them along if and when I find them, because I do know I had my hands on some clinical pathways in the way back when. So I will look for them, and Kristen, I'll send them along if and when I can't say it specifically. I have those conditions, but it might be a link at least to see if they have those conditions. So I will look to see what I have and send that along.
Sure. Thank you. And maybe what we'll do is, if any of y'all on the call today have visited our website landing page for this series, which is www.pcdc.org/integrationworks, and it'll be in the email that goes out with the slides. Maybe we'll add a little button there that says resources. So if folks have resources that they're asking for and our experts identify resources, maybe we can just like put a little list at that button that folks can download so that we can follow through on that if we find any. Deb, did you have any examples of a care pathway or procedure that comes to mind around these topics?
I have to go dig in, the crates as well. I have. The problem is that looking at there was an STOH request on here I saw before it flipped up. I will look. There wasn't one for STOH. I saw one for prepare, but I'm not sure if it was quote unquote a clinical pathway. It was just an adoption model. But I will definitely look to see what else I can pull together. This one I have one for future reference. Okay.
Thank you.
Yeah.
So Mallory, I really like this question. Yes, I know I have experienced leadership saying that they want integration, but not fully understanding what it means, and therefore being hesitant to give clear direction on practice changes. I have also seen this particularly when leadership or a branch of an organization goes after funding or a grant for integration. And then once the grant money is distributed, not fully understanding what will go into it in terms of partnering, in terms of breaking down silos at the organization, in terms of redrafting and reconfiguring policies, all the way down to the nitty-gritty of understanding what it means to have, if this organization has an EHR system, how to make it communicate with, if they're BH, with primary care or vice versa. So yes, this is very familiar to me. I think every situation like this is different, and I think only you or anyone on this call, you know yourself, if you're in leadership, or you know your leadership best, or you know your board best. And it's sometimes a conversation around, you know, you're on the line for federal dollars and these are the deliverables, and how are, to, you know, what was being said earlier by Deb, how is the authority and autonomy going to be distributed to make those possible? And sometimes it's just some education. It's some education about the value that integration has, which is, you know, something that Dr. Bell was speaking to as well, and saying, okay, we're now on the line for this, but that's not necessarily a bad thing. It's going to take some work, but how does doing this, you know, care pathway of integration work for achieving our mission? How does it align with our sustainability and potentially, you know, value-based payment systems? How kind of being able to do a little of interagency marketing can sometimes go well. And also sometimes being, if your leadership is open to it, recommending that they connect with folks, not trying to but folks like ourselves or other folks who are in the space. There are free resources available and such, so that they can get the information they need to feel more confident moving forward in the space. I think Dr. Bell articulated that in the future, things are going to be a little bit different, but sometimes folks in leadership aren't currently in med school or aren't currently in a social work program and are not hearing about ways that collaboration makes us stronger, provides clients with a better opportunity for positive health outcomes. So I think that what you're sharing here is really normal. And there's a lot of different ways to approach it. And if it's taking a long time, that doesn't mean that you're doing it wrong, is I think something that I would also say. Change takes time, and shifting systems can take time. And sometimes just finding a buddy or finding champions amongst other individuals at your organization can also really make things go a lot smoother and can be really validating as part of that. I don't know, Deb, Dr. Bell, or Maia, if you'd have anything to add to Mallory's question there.
No, you said it all.
Oh, thank you.
No, nothing to add.
Well, thank you. Okay, request for resources, hiring resources. We'll see if we can dig those up from these lovely archives that we have. Oh, Melissa adding, oh, it's other agencies. Yes, ooh, that is then, in my experience, a practice in curated buy-in, in figuring out the intentions, motives, and I mean motives in not like a negative connotation way. I mean it in terms of what do the other organizations need? Why did they join this party to begin with? And identifying ways to cultivate alignment. And sometimes that's as simple as sitting down and having, you know, coffee with someone and just getting to know them. I will say it can be very hard when folks are at other agencies because there is sometimes nothing you can do about turnover or who they might send, especially if it's like a satellite program where you're sort of getting, you know, a different primary care provider every day or something like that. So,
but I would also say though that it still is a meeting of the minds when it comes to leadership.
true.
You know, what I think of when the first thing that popped into my mind when I saw that your comment, your clarification, Melissa, was that this is akin to me to a co-management agreement. So your agency is working with another agency and you're agreeing that you're going to co-locate services, it sounds like, within this one, you know, physical place, the health home. So what that means is that each agency has come to the health home with their, whatever their level of responsibility is. However, they've agreed to work together to do that. And so part of that agreement should include working together. So I think, you know, the comments that we made are still valid, that it is still above you, but it's the leadership of the agencies that need to talk and say, you need to make sure that your staff understands the level of collaboration that is needed when it comes to servicing our clients within the health homes. This is not, you know, a one-man shop. We are all working together. So I think you know, and it sounds like it's not yours to manage, that it's still, you know, the leadership above you that needs to talk to the leadership above the people who are not working well or playing well with others. So.
Yeah, got it. Okay, so I'm so sorry. I know that there are still more comments, but we are at 2:30. Chaim, if you want to go one more slide, we can leave it on my face and my email. We're going to send out slides for this. The recording for this will be up. If depending on what we're going to dig stuff out of the archives. If we find things that will meet sort of the questions, we'll add that on like a button or somehow on our webpage for this. Thank you all so much for spending the last 90 minutes here. We really appreciate it. We appreciate what you're doing. It is complicated, and as you're hearing from this conversation right now, there's not always a solution. There's sometimes just different avenues that you can go down, and there's not one size fits all. And that's why integration, I think, is so critical, because there's not one size fits all kind of care for a client. And, you know, kind of the reverse is true. There's not one size fits all to make integration work at an organization. It takes all of the information you learned here today and the information that you already have from the wisdom of the work that you do. So I think that wraps it up for us today. Everyone take care and enjoy the weather, to harken back to how we opened today, the weather in your designated areas. Be safe, and we hope to talk again soon on our 4th webinar. Bye all.
Bye. Thank you, everyone.
Bye-bye.
Okay.